Neck retraction extension is a very important repeated movement test. I have this chair here so I can show you how it's done, but I use it for nearly all patients with suspected disorders of the neck joints. And that of course can present with neck complaints, symptoms in the neck like pain or stiffness, but it can also present or create symptoms in the shoulder blade, in the head, face, jaw, in the shoulders, and anywhere down to the fingertips. So as an orthopedic test, what I use a repeated movement test for is to figure out if the problem is mechanical in nature, meaning that the joints or one joint or many in the neck are not moving perfectly well, and moving them in a specific direction or two repeatedly will get them back on track, so to speak, and resolve all the associated signs and symptoms. This idea, this construct, is not accepted in mainstream orthopedics, but this mechanical nature of problems is what I find in about 70 to 80% of patients' orthopedic disorders. Now, most people think, well, I'm not one of them. We found this on my MRI, or I'm not one of those 70 to 80% because my other clinician said it was XYZ. And I would put forward the idea that no, on the whole, even with MRI findings, even with disagreement between clinicians, I find 70 to 80% of orthopedic disorders can be fixed by moving a joint repeatedly into the direction it needs. It's usually just one, but sometimes it's two movements. So neck retraction extension involves retracting the neck first until the spine is neutral, and then extending as far as you can go with the neck. Now, some people may not be able to go that far due to pain. That's okay. If we can't get to end range initially, we will get there eventually because it's crucial to get to end range. And I've mentioned before that sometimes I have people use training wheels or use their hands to bring their head back to neutral if it's too much stress on the joints. Ultimately, the goal, of course, is to not use hands on the way back up, because when the joints are working and moving appropriately, your neck can return from extension to neutral without any distress. So retraction extension looks like this. Retract, extend. Now, I have a chair that hits in the correct spot in the mid-back. For people who are shorter or taller, we may need to adjust it. Sometimes if the chair back that the patient has at home or at the office is too tall, they can sit on something. But the point is to take the neck back first, parallel to the ground, and extend as far as you can go. If you don't have a chair that's helpful, that's fine. People can usually do just as well doing it without any back support, just in sitting or standing. For most patients, we will end up adding overpressure to get to end range. I've said this before, but it bears repeating. End range is where the magic happens. Going all the way is what we need, but because of chronicity or vulnerability or other factors, we may not be able to get to end range on day one. There's many patients with neck disorders that we cannot add overpressure to the chin to get to end range extension on the first day, or maybe even the second. But once we get more motion, the patient can tolerate adding more pressure. When patients press back and get into full retraction extension, I tell them they should be getting, a centimeter or two more than if they did it without their hand. So retraction extension of the neck, number one, is a test. It's a repeated movement test. So that means as a test, we take all the physical baselines, range of motion of the neck, range of motion of the upper extremities if indicated, nerve tension if indicated, strength of the upper extremities. So we take the signs and we take the symptoms. What do you feel? If the symptoms are not present at this very moment when we apply the test, then we will monitor over a few days by noting what the symptoms are on a daily basis and if they're changing with this test. The test, therefore, is doing 10, usually every 2 hours, outside the office. If we've shown that there's some utility in using this in the office, then it becomes the home program. And as a test, we are assessing when we do retraction extension, what happens to all those baselines we took in the physical exam, what happens to the symptoms we've already written down. Therefore, the treatment is piggybacking on the testing if the testing is showing us signs and symptoms are improving. If the test shows us no change, then I may choose another repeated movement test, or I may choose a ligament test, or I may choose an imaging test. My job as a clinician is to use the best testing we have possible. And I think repeated movement testing is almost always indicated with patients because it will tell us if this is a mechanical problem that can be fixed with a movement or two or not. But if the verbal history and the baselines in the physical exam tell me that there's a high likelihood that this is a mechanical joint disorder, then of course we are going to use repeated movement testing. But we can call it treatment if we start to see positive changes. Then we can say the retraction extension is just a treatment. It's kind of semantics at that point, but think about it like this. We're doing 10, 20, 30, 40 repetitions and assessing the effects on the baselines in the office. And if there's some positive effects that I deem are worthwhile enough, then I think that's proof of concept that we need to do more repetition outside the office. And if more repetition shows us that yes, neck retraction extension is resolving signs and symptoms, then we consider it the treatment.